Well, good afternoon. How are you doing? Good, good, good. So thank Dr. Turner for inviting me, and certainly my good friend and fraternity brother, good Dr. Brian Turner, for having me here at Xavier. I'm new in town. I'm from Houston, Texas area most of my career, but I've been here in New Orleans in a role, as Dr. Turner points out, as the chairman and the assistant dean for what previously was called diversity, and now is affectionately called community engagement here at LSU, I think in many places around the country. For about the last 3 years now, got here in 21 alike. I'm a psychiatrist by training, so this issue regarding mental health is so near and dear to my heart. Early involvement in some clinical research and a great deal of clinical work. But I also trained, so specialty trained in forensic medicine. So I'm a forensic psychiatrist. And about the second decade of my career outside the clinical work, really involved, I think, and engaged in conducting forensic assessments and determinations, I think, very often for medical legal issues. There's a research bent, not strictly bench research, but of a fair amount of, I think, overlap in these regards. So huge issues, I think, of great commonality in today's discussion. So I'm certainly thankful again for the opportunity to discuss this today. But about the last decade, I've really been involved in issues regarding health disparities, which we increasingly now focus on health equity. I wrote a book on gun violence in 2018 and a follow-up book on domestic violence in 2021. They both address issues regarding fairness, equity, and I think issues regarding diversity in these regards. So huge issues that I think are very much in commonality with the kind of work that's being done here at Xavier. So very happy to be here at LSU in New Orleans and have opportunity to partner, I think, with groups, I think, in this setting. But I have to admit, today's a unique day for me. A lot of talks over the years. I also was president of all the Black Doctors, the National Medical Association, about 10 years ago. But I've actually never been asked to give a talk with an entitlement of HBCUs. So that kind of warms my heart. I would be remiss if I didn't say that I think I'm about as HBCU as a guy you're going to meet. I went to Morehouse College and finished an undergrad 82 to 86. Absolutely. As a brief aside, the last year that Morehouse had more black males go to med school than Xavier was probably 1986. Xavier's been doing, I think, that job at an outstanding rate with Dr. Carmichael, who's retired now in that group for the last 3 decades. I actually served as assistant dean for education at CDU UCLA Drew in Los Angeles. And I served as chairman of psychiatry at Meharry in Nashville from 08 until 2014. Although I never actually worked at HU, and I have some friends in the audience who are Howard fans, the National Medical Association probably is kind of a secondary version, I think, of HU in DC. So I feel like I've touched all of the HBCUs throughout my career and have done a lot of work on the National Medical Association side, trying to work to bring in funding for activities, including research in those settings. So kind of my backdrop for today's consideration and today's discussion. The topic is HBCUs in the future of black men's brain health. So when Eric Griggs, I think I was trying to call, asked me a few months ago about this discussion. Of course, I had some energy and excitement in trying to find ways to link it to much of my own research that I've been involved in here. A lot of that work is on dynamic violence and addressing issues regarding gun violence, I think, in the community. But I think it sort of goes without saying that our construct of determining where the overlaps are on issues regarding what most importantly adverse affects our community is essential for us to think about developing research paradigms and models likely to create, I think, models of care that I think have a societal basis with individual overall potential benefit for persons who are particularly adversely exposed. So that, I think, really is the rubric of what brings us to today's discussion. There are no disclosures today that are relevant for today's comments. A few statistics. So my team and I really worked to look at what might make sense in this discussion. And we thought the backdrop, certainly for many, is the whole issue, I think, of what happens when the brain doesn't work right, when things go wrongful. And I think the issue of dementia, the most generic diagnosis for brain dysfunction, is key and instructive. Early in my career, a lot of discussion was around what we call MCI, or mild cognitive impairment, that African Americans have more than, I think, other racial groups, and may be kind of a preliminary or early determinant of who's going to develop a dementing diagnosis. But we do have data currently that makes it very clear that African American men are at a higher risk, twice as likely to eventually develop dementia than others. And a number of issues that come into play. Some are sociological, some organic, some have a biogenetic underpinning. Others, I think, are much more societal and I think environmental in their scope. All issues that I think much of the discussion and engagement at HBCUs can go a long way toward early interventional educational considerations. And I think when you get to med schools, developing some strategies based on research that may be a lot more determinative in their approach. It also shows that there's a sociological component involved in healthcare that I think we all recognize. That's a nice way of saying there's discrimination and there's bias. Because the reality is, although African men tend to show up a lot more likely to have dementing early signs or risk factors, they're less likely to get the diagnosis. The second bullet points out about 65% reduced odds of getting a dementia diagnosis. So we not only may have some higher risk, we also may have, based on our society and some issues we'll discuss here shortly, a greater propensity, if you're at risk of developing dementia. Thirdly, we may also be less likely, no matter who the doctor is who's going to assess us, for the diagnosis to be missed, and therefore the missed opportunity for an early interventional strategy that may be, I think, determinative in helping manage those concerns. Not good from a physician's perspective, really bad, I think, from a researcher's perspective. And finally, this underrepresented piece, I think, regarding having Alzheimer's specifically. And what are some of the symptoms that we consider? Clearly, I think in psychiatry, we have the focus, I think, on clinical symptomatology. So I like to always tell almost any ERs I speak to about kind of the big issues of clinical issues regarding depression or bipolar disorder, concerns regarding anxiety, irritability and stress, issues regarding SUD, substance use risk, and then the huge problems that I think lay people discuss most specifically are when you develop what we call psychosis, the big five, so-called Snyderian symptoms of hallucinations, delusions, paranoia, or disorganized thought or activity, and the worst issues being catatonia. All those issues very often in a paradigm or model of growth can occur in this consideration. Very often the big issues of being psychotic are much more likely to be inherent once somebody gets a dementia overall diagnosis. And the last bullet kind of points out the key issue that we have to consider this in psychiatry within the construct of what's functionally impairing. So a person very often may not be diagnosed if they're alone, they can maintain some of the levels of functionality or experience. One reason often I think these issues are missed in Black males is that if those around us in our home and our family, I don't know if there's a job or a work setting, if the expectations of us are less than, it's easier to miss when persons begin to have cognitive impairment early on, and then some of the functional impairments behaviorally that may be earlier signs and moderate signs of a dementia diagnosis. Huge issues, I think, we look at areas of future consideration regarding research. That chronic mental illness that we call so-called SPMI or serious persistent mental illness comes into play is key. Goes without saying that issues regarding homelessness are very relevant in these settings. As persons get older, if they can't think appropriately, if they're disorganized, if they can't manage all of the challenges that occur, if they don't have family or friends or associates to do that for them, then very often I think SPMI or serious mental illness can entail, and they might not be able to meet the basic responsibilities of life, including housing, clothing, and shelter. That substance abuse disorders come into play, I think, are also very relevant. All too often we try to so-called self-medicate. Many may tend to do so throughout, I think, the spectrum, but for African males, for any number of reasons, I often argue most notably because of the stigma of having a brain illness, despite other types of illness, it's easier to very often reach for alcohol or things of that nature rather than go to a doctor for more formal kinds of treatment. And very often that kind of worsens the construct. What you're likely to see early on, though, are issues regarding mood and emotional lability. The downs of mood, or so-called clinical depression, we call it unipolar depression, or the so-called ups of mood, hypomania or mania being key symptomatic concerns, are huge issues regarding our assessment of how brain health, when it's impaired, are likely to present. These issues very often that should not be missed. We would argue all too often they are missed if either A, the clinician is not culturally sensitive and aware that these are the same kind of problems that may occur in Black males as other demographic groups. They're also likely to be missed, I think, at times if there's undue what's called familiarity, and if we assume that everybody tends to act that way. No, you don't just get old. Whether you're 45 or 65, your brain should work in a certain way. You should be able to typical executive function with thinking and concentration and memory and attention span. Those issues should not, in many settings, be impaired. There can also be environmental exposures or toxic exposures. A lot of focus on violence. I'll spend some time on that here later. And of course, we'll talk a little bit about head trauma. So all issues of future consideration regarding brain health, I think with a particular focus on black men, there's a lot to be said because there's a lot that we can do, and in my opinion, a lot that we can do better. Head trauma. So a lot of discussion increasingly now with the football game coming up Sunday on the issue of head trauma. I spent some time when I was chairman, I've been here for about 4 years. I was chairman at Wake Forest in North Carolina for about 4 years before I got this role. And there we had a program in conjunction with Virginia Tech looking at CTE, this idea of chronic traumatic brain trauma, brain impairment. We were trying to, we got some research money to essentially get helmets for these two football teams to kind of manage or assess the level, I think, of chronic violence to one's brain over the course of a full season. These are some of the strategies that I think are increasingly engaged now to try to better understand what I think are some of the chronic lower lying presentations, I think, of brain trauma. Well, and football is one example, not the only one. Other sports like boxing can occur. It can occur, I think, in soccer with girls if they're running and the like. It can occur outside sports with car wrecks and things of that nature. One thing that's key, though, is you may actually see this more commonly early on in African-American females than males. We should be mindful of that. And you certainly can't say that in some groups that are not African-American. But that blacks are underrepresented, as the slide shows, in clinical research in this area is key. We even point out that it may in part be because a lot of it has been done on persons who played football years ago, and at some time ago, you did not see as many blacks that you see now playing football at the collegiate and the pro level. So head trauma issues, I think, are relevant in thinking about the development of Alzheimer's disease and dementia. There are also additional challenges in dementia research. The reality is similar, I think, to what our dean at Tulane School of Public Health, Tom LeVice, mentioned when I was here yesterday. The issue of mistrust, I think, is rampant throughout many groups. And my experience has been similar to his. We see more mistrust of black males when it comes to clinical trials as compared to the other forms of research. And that certainly impairs our ability to have larger numbers, or so-called N, or number of persons involved in a study, so that we can actually extrapolate results we do receive over a course of time. So we have small groups with small numbers of African-Americans involved, and that very often limits, I think, what value we can glean, I think, from those studies. So we probably can't speak enough today, yesterday, and going forward to really try to work to discourage or decrease the amount of mistrust there are in studies by education and by sharing this information, I think, with others academically in studies like today. But when you go home and into your communities, speaking to your families and friends, it probably is going to be a group effort to work to undermine, I think, the prevailing mistrust in clinical studies. But we can do more than that. In addition to us talking to people, we can also try to find resources to make things better. I clearly believe that we probably should have more African Americans at every step along the pathway, from recruiters for clinical trials, to persons who are actually involved in scales. We do a lot of scales, I think, in hospitals doing clinical work, to persons who are evaluating and assessing the data. It's very difficult when there are cultural missteps along the way, and we don't have persons, I think, engaged who may meet, I think, a cultural sensitivity process with persons who are then asking to be involved in trials. I did a lot of work on that yesterday, so I'll repeat all of it, but these are huge issues, I think, going forward. The bullet points are, there are several, but the other one I'm going to kind of comment on is this issue of social determinants of health. So it also goes without saying that if you have many of your basic necessities that are not being met satisfactorily, let alone optimally, housing, food, clothing, shelter, education, familiar health concerns, it's very difficult to make this a priority in your life. To find the time to go, let alone do it, I think, with a clear mind and a clear conscious approach. Those are some issues that I think we notice in challenges of study design that can be managed a lot better. So I found it in my studies to be better, more so than just, although it's beneficial to give the Starbucks gift card, and I think somebody mentioned yesterday it would be optimal to have, I think I heard somebody say $100 an hour or $800 a day. I love those kinds of numbers, the work we've done. Often I think the numbers have been much less than that person are deciding to do it out of the goodness of their heart, because they actually very often they actually are losing money, losing valuable time. That's an odd circumstance to put anybody in. Reasons why there's been challenges in study design that's been in many regards problematic. Now, there have been activities that have occurred that I think have been helpful. This 1993 issue from the National Institute of Health, this Revitalization Act, directing NIH to create guidelines for including women and minorities in clinical research, has been helpful. I think the numbers went from we have 4,400 to 7,500. Not astronomically high, but it shows that it can be helpful beneficially. We probably have to kind of keep the pressure on and the pedal to the metal, asking for and pushing for more activity. I do think there's a lot of value in having more funding go to HBCUs, having research conducted at those sites for obvious reasons. That's a lot more likely, I think, to work along this overall process. But by definition, because I've been at both HBCUs and non-HBCUs, think that everywhere where you exist, these issues should be in play. And that should be an effort to try to push for more active effort to recruit and even more importantly, retain African Americans, especially men, in these type of clinical trials. These issues, I think, address issues of equality long-term, but lead to health equity models or patterns, because we want to be able to provide data that's relevant, beneficial, and actually has some, I think, degree of value for all communities. Huge issues for why participation in randomized clinical trials really matters. Now, a bit about the pathway, I think, to improving brain health. I mean, clearly it goes without saying that understanding the big diagnosis and early assessment and some diagnosis and treatment patterns do matter. There's probably a lot more that we can also consider in how to address Black men, especially middle age to third age range of Black men in this setting. One point out this issue, I think I mentioned earlier, is cultural competency in research. And I think cultural competency can be, I think, a theme that any and all individuals can manifest. You don't necessarily have to be African American to be culturally competent with African Americans. You don't necessarily have to speak somebody's direct language for health literacy to understand that their culture may be different and how you engage with them may be different. I may not speak Spanish, but if I'm taught and trained that the way to engage someone who does speak Spanish will be different than somebody who doesn't, I could actually learn if I take that as something that's important to me, and if I choose to acquiesce as a professional and try to meet that culturally competent need. I think that actually, I think, is key and important. My 30-year experience in academic medicine as well, and organized research work, has not unfortunately been consistent with that process. I think that we could do better there. I think we probably have to hear it from the top. So it doesn't matter what you hear, I think, from who leads research in Bethesda, let alone who leads it, I think, in Baton Rouge and in New Orleans, I think would be our example. I think I point out here, to be in this unique position to really push cultural competence is essential. One has what I like to call a bully pulpit, so this actually matters. And I think our challenge has to be to make sure that it matters to everyone. We get it when it goes to things that are communicable. When COVID, for example, was rampant early on, many appreciated that whether I had COVID or not, it was important to me that you not have COVID so that I can go to the grocery store and breathe the same air with you. My contention is that may actually have relevance across the full spectrum of illness, including brain illness. Many others, I think, have to, at some level, grow to appreciate that. That actually means we probably have to have a nationalized educational program. I'm a strong believer in what we call repetitive messaging. It probably requires more than one conversation or communication, and I think very often there has to be some backup data. So I like the fact that often we find, I think, important times to discuss these issues, nothing more so than a football game, the big Super Bowl, and football players and teams and groups, because we have people's galvanized attention now. It's our challenge to kind of keep that focus on, even post, I think, this big event or other big events. We sit in other settings too. I mentioned I'm a forensic trained person, so there's a lot of media. A couple weeks ago, we had the tragedy January 1st. I wrote a book on gun violence, although that wasn't a gun violence issue, it was a violence issue, huge amount of discussion. But that issue of January 1st, similar to other gun violence challenges in our society, the one in South Carolina, the one in Buffalo, the one in Missouri, the one in Texas, El Paso, Texas, tend very often for people to, if not forget, it ceases to be as intensely focused on a priority for them kind of going forward. And that's like the challenges in making the moves we have to move to actually change and alter thought or behavior. That's true, I think, in the violence discussion. My experience is that it's also true in this discussion regarding men's health brain health, most particularly black men's brain health. So we got to find a way to kind of keep this on the front burner of importance and priorities kind of going forward. I'd also say that when we do develop studies, the so-called methodologies of how they're developed attention matters. We note here that we talked before about getting people more engaged in trials by asking them to join, and we provide some kind of a financial value, getting people to at some level appreciate that what they're going to engage in does help someone else. I would never speak against that, but I think we can do a better job identifying how it's likely to help them or their community. A friend of mine, Eric Grieg, said from this very podium yesterday or on Monday that we probably don't do a good job getting that communication, that information back to a particular community. He's right. That's in my experience as well. We probably have to be much more forthright in our approach, I think deliberative, I think in our communication strategies, and I think much more effective in emphasizing, whether we do it through churches, whether we do it through community groups, whether we do it through the written word, that your involvement in clinical trials does matter. It matters to you, and it matters to your community, and it matters now. It's not only a long-term esoteric kind of issue or consideration. And I am with this bullet that, again, we still address this issue, I think, of trust, and trust that somebody's not necessarily going to be mistreated. I still hear people use this term guinea pig, where we ask them to be involved in clinical trials. In 2025 we're doing a pitch now on the issue, and that issue still comes up. So what gets me is if somebody will say it periodically, 10 people, or 10 times 10, may be thinking it. So I'm at a disadvantage if I don't know that, if I'm not actually addressing what the real barriers or hurdles are to get people involved in clinical trials and to remain thus over time. So we talk about these 3 C's, this consultation, communication, and collaboration. Huge issues that I found to be extremely important in this type of work. Consultation simply means that I should show you the respect and the umbrage and the fairness to consult with you in a bi-directional way of communication. I love from the forensic literature, we use this term, that often when you're in this business, you're what's called the learned intermediary, one of my favorite terms. Yeah, you're the doctor, you're the researcher, you have all of the years and titles what have you, so you should be learned, but you really are intermediate between the person and the decision. It is their decision, and you want them to not only make the decision, which we historically have pushed for, but you want them to buy into that decision. And people don't do so, they don't stay in the trials. Similar to clinical medicine, where the data will argue that black men are the group most likely to go to a doctor, get a medication, prescription, pay your copay, and do all of that, and never get the medicine filled the first time. That means there's probably something that happens after they leave my office. It has nothing to do with the discussion we had ongoing, but something that they actually knew before they came to my office that blocks them from going and getting that prescription after they leave. It's my job to recognize that and to talk to them about whatever that issue is when they're in my office the first time. If I don't do so, I do that at my own peril, my own detriment, then I'm likely to lose them to follow up before they ever took the medicine the first time. The same, I think, analogy is inherent in this discussion about getting black males in clinical trials. Consultation matters. I think this communication is key because we communicate, I think, in different ways. As an African-American psychiatrist, I've, unfortunately, you could argue, often been in settings where I was the only black doctor in that group. I trained in Houston. I think there was 2 of my 4 years, I was the only black doctor in our residency group, 14 a year, so 56 residents total. I think 2 years there was one of the young black male there. So all of the black male patients all too often, many were kind of referred in regards to me. Part of the challenge, though, is that many other Caucasian residents went through their whole residency without doing any outpatient work with a black patient. So they probably ended up going through much of their career, and when a black patient walked in, a lot of things you actually learn in residency, the communication strategies, what's humor and what's not humor, what jokes can you make, what can you not make. When is somebody really engaging with you and trying to say something kind of nice and deal with it, a lot of that was missed. So a lot to be said for who we refer, but also how we balance training and how we balance, I think, our engagement with individuals to make those interpersonal experiences make sense, make them worthwhile. I think it's those kind of informal social engagements or lack thereof that are often is problematic both in clinical medicine and why black patients don't get that medicine filled the first time. Also in research considerations, why people don't go to clinical trials or stay in trials, I think, over time. we've got to find ways to improve and make communication better for and by and of clinicians and researchers who engage with Black males. My argument is it has to be the responsibility of the clinician and the researcher, not the responsibility of the Black male patient or researchee, participant, to make that communication work. And the final point on this slide is collaboration. There's got to be fairness, there's got to be equity, and both sides have to feel like they actually are gaining something, I think, in that setting, in that regard. Goes without saying, both sides can gain. The researcher definitely needs entities involved. You don't start doing somebody a favor because they're kind of doing you a favor. That can be real and perceived in the interpersonal exchange between the professional and the person you're speaking to. So collaboration, communication, I'd argue, and consultation, huge, these so-called 3C models of participatory community engagement and ongoing research. How we interpret the data also matters. Recruitment, retention, and attrition issues, I think, are huge. We should have large enough samples for the data to matter. I mentioned that piece earlier. If we regularly have these very small numbers of Black males in trials, we do wonder, does the data actually matter? It's consistent for us, I think for others, reporting, and I think key issues going over time. And we also know that I think that the diversity, I think, of all persons along this business matter is not just the headline researcher, but whose name I think is on the trial, but the many individuals who you work with and engage, they touch and engage with individuals along the way. Again, very good program. I was here half of it yesterday. I think I heard one of the other panelists comment about the fact that the person who may make your participants stay in the trial or leave the trial may be the person who took the initial information, maybe the person in that admin type setting. If they say something that's a little sly or gives an adverse wink at the wrong time, they may send a signal, this is not one you really want to be involved in. On the same token, if they actually have bought in to what you're doing, believe in it, or engage and have kind of accepted this is actually good for themselves and their community, whether they're in a trial or not, they can send signals that are very, very important. So I think we, at our detriment again, miss the importance of full representation and engagement of all persons touching individuals we're trying to recruit with. Very often, I think that recruitment occurs from the time you're putting the flyers up and person making an initial phone call to a lot of the initial engagement. Persons are trying to decide whether it's something they'd like to be involved with or not. So the importance, I think, of diversity in this setting is also key. And I think that this issue regarding getting other doctors to be involved are key. I mentioned earlier I was president of the Black Doctors here in the US by 2013, the so-called National Medical Association. And one thing we've always done well, I think, is find ways to link Black doctors in private practice who may not have a full research portfolio to research paradigms and models with groups that have the research infrastructure. We call it Project Impact. We've had that funded for over 2 decades now. And it really, I think, has been an effective strategy, although I'd love to see it, I think, occur with a bigger footprint along a larger model, by finding ways to access Black patients, very often in private doctors' offices, but also with doctors who believe in the trials. So I think that all too often a therapeutic alliance exists between your primary care doctor and the researcher. The primary care doctor can then pass on, I think, the same degree of credibility and veracity, I think, of trust and engagement with them for you to then choose to be involved in the trial over time. When I finished in the president role, Joan, just for 9 years, we have a research arm called the Cobb Research Institute. And that was our responsibility, to try to find strategies to get more African Americans involved in clinical research. Programs like what you're doing today are hugely important, and I commend the entire group for the organization. Cobb has spent 30 years now trying to do this. This is really hard to do. These are not, I mean, it's much easier said than done, but it's my experience. But the kind of education occurring today, and this week I think goes a long way toward meeting many of the key challenges that I've seen that I think are not insurmountable, but probably require collective effort and repetitive ongoing activity and messaging. I simply have this point to argue that the key catalyst to all of this is to change in education. We have to kind of be discussing these issues in all settings. I'm often struck by how in so many places now, when there's a discussion about how do you communicate with Black males, there's a discussion about using barbershops. We do a lot of this now, I think, in this whole violence arena, how we talk about violence prevention strategies, so-called risk aversion strategies, issues regarding how to de-escalate conflict, and entities try to do this now in barbershops. Probably because very often, many barbershops, all the persons are male, good or bad. All the persons will be African American, good or bad. So it may create a different cultural discussion environment than many black males have in other settings. But all too often, the conversations are much more academic and professional and forward-thinking than simply about many of the fun issues that we all want to talk about briefly, something that's social. So we got to find the right places to discuss information that's the right information for the right people. Whether it's barbershops or other settings, think about that as you consider ongoing strategies to enhance pro-education measures to think through how to get more black males involved in clinical research of the brain. We also point out that I think we should think about our pipeline. We spent a lot of time in the National Medical Association discussing pipeline issues. I think that the Turner mentioned I have this title of Assistant Dean for Community Engagement, and one of those issues simply is recruiting. We're trying to recruit more black males, all African Americans in that regard, at LSU, like everybody is. So the challenge to get persons in the biomedical sciences on the research side and on the medical side is extraordinary and it's extreme. We, like most places, easily have 20 times as many applications for qualified people than the spots that we have for every seat. So the challenge, I think, is high. So as great as it is that we discuss how great Xavier is getting more people in, I think, than many other schools. I don't think I got to have it about Morehouse. But my challenge has got to be whether you go to Prairie View where my father went, or Texas Southern where my mother went, or Mississippi Valley, or Jackson State, or Tennessee State, whatever the case may be, there are quality people at all those places who'd be a good doctor, research or clinical. Our job has to be, those of us who are at these settings like where I am, to find ways to get the information that is needed to those entities, those individuals, to make sure that they can kind of get over the typical hurdles that we can predict. It's the same 2 or 3 hurdles that trip people up. It's not a secret. But getting information to them, to make sure they do the things in advance to avoid such, I think is key to addressing, I think, pipeline issues and developing, I think, future professionals along that line. So this point just kind of emphasized that if developing researchers, huge issues that are relevant. We already have a group that are underrepresented in healthcare, so it makes it even harder to get them to go into research. A lot of folks go into research out of a healthcare orientation. You want to be a doctor. Once you get into it, you decide that you're better on the research side. So getting people into the clinical piece initially, I think, is a start. I think training matters, and the earlier we start with training, the better. All too often, we push people out of training earlier because of funding. And of course, a lot of it has come from the federal government setting, so we have to find ways to find groups to fund these projects. Funding matters. Hard to do research at this level if you think about kind of paying the bills. That's what often pushes people into other type work, especially clinical work. And of course, we look at other issues regarding how to engage students, how to provide experiences, how to do mentorship. I started a program about 14, 15 years ago when I was at studying at Harry, and we call it an externship program. Started in 2009. And little could I have known how much individuals who didn't get into med school the first time would be willing to go into research if they had a good opportunity. So we found some funding, linked it onto some state grants, and got persons doing substance abuse research, I think there at the Elam Mental Health Center. And it really worked out very, very well. This has been ongoing now for about 14, 15 years. About 56 people now have gone on to get into graduate school. Some did go to med school, and some went to do the PhD. But it does show that finding ways to get persons started rather than losing them early on is not only a pipeline issue, it's a substantive issue, I think, for fulfilling these professional roles kind of long term. And it's remarkably important because we also have the adverse data that black males in our country are the group most likely to go through the whole process. They go to undergrad, they major in pre-med or pre-dent, they take all the classes or whatever, maybe take the MCAT or the dental admission test, but never actually apply. Either they think the score wasn't high, or they got bad advice, or lack of mentorship, or a confidence issue, or stigma, all kinds of issues. That's gotta be our space. That's gotta be something that somebody can say or do or engage in and not lose one person who could have ended up being a good clinical and academic researcher if given an opportunity and the appropriate mentorship and push, I'll call it, early in that setting of their career. I kind of end by just saying that we are having some challenges, some uphill hurdles. I think it's my last slide. So my researcher we were looking at this just today, and you probably have heard that 2 days ago, a lot of information that was on the NIH website about the number of African Americans involved in trials and getting involved in studies has been deleted from the site. So I thought it not to put it in. I hope I've given you an uplifting and engaging kind of talk today. I don't want to end on the negative, but this is about as negative can be, and it is what it is. So the fight is real, and it's going to take all of us, I have no answer for it, to be as engaged and involved in addressing these issues as we can. So that being said, I'm going to do something that my daughter said. I got a daughter finishing a PhD in a clinical psychology in Atlanta the other day, and she sent me something that said, that there was an attempt to, at the national level, block some of the things we've taken granted for a long time. So I'm going to end by simply saying, Happy Black History Month. Happy Black History Month. Happy Black History Month. It's Black History Month because of the way we think and feel, not just because of what somebody else says. Thank you very much.